Welcome to this comprehensive presentation on coma due to primary brainstem and diencephalic lesions. Coma represents one of the most challenging clinical scenarios we encounter as neurologists and critical care physicians. Today, we will embark on a detailed journey through the functional neuroanatomy that underlies consciousness, the pathophysiology of coma, and the systematic approach to assessment and management of comatose patients. We'll explore how lesions in the brainstem and diencephalopathy dientic structures, specifically the thalamus and hypothalamus, can profoundly disrupt consciousness. By understanding the intricate neural networks responsible for wakefulness and awareness, and by mastering the bedside examination techniques that localize these lesions, you'll be equipped to provide optimal care for these critically ill patients. Let's begin this important clinical exploration. Since the 18th century, physicians and scientists have hypothesized that specific brain regions, particularly the higher brainstem, hypothalamus, and basal forebrain, are fundamentally responsible for maintaining wakefulness. Consciousness, which we define as the mental state of wakefulness encompassing self-perception and our interpretation of interactions with the surrounding environment, is extraordinarily complex. Over the decades, researchers have dissected the different levels of consciousness in systematic attempts to understand, diagnose, and treat various pathological states. Grossly speaking, we can conceptualize consciousness as comprising three main components: alertness, which is the basic state of being awake; awareness, which is the recognition of self and environment; and attention, which is the ability to focus cognitive resources. This tripartite division makes the understanding and anatomical localization of consciousness an ever-evolving field that continues to challenge us. The practical challenge for bedside clinicians remains to dissect which specific components are implicated in the present pathology, to propose a rational differential diagnosis, and to delineate the needed diagnostic and therapeutic approach. Before we delve into the details, let me highlight the key concepts that will guide our discussion. First, the functional anatomy of consciousness consists of multiple distributed components working in concert, with specific structures being responsible for maintaining wakefulness. Second, the assessment of comatose patients requires substantial clinical experience and a sophisticated understanding of functional neuroanatomy to accurately localize the culprit lesions. Third, and critically important for patient outcomes, rapid and systematic assessment can identify and address immediately reversible causes of coma, such as hypoglycemia, opioid overdose, or hyponatremia, thereby preventing further and potentially permanent neurologic consequences. Fourth, we now have access to surrogate tools, including electrophysiological studies and advanced imaging, that help assess the state of arousal and have demonstrated higher predictive value for poor outcomes. Finally, it's essential to recognize that most current research in coma has focused on traumatic brain injury and post-cardiac arrest patients, and extrapolating findings to other causes of coma requires appropriate caution. To understand coma, we must first understand normal consciousness. Consciousness fundamentally encompasses two distinct but interrelated dimensions: content and level. Content refers to the means by which information is obtained from the environment, collected and integrated in the brain, and subsequently reacted to. This includes the function of afferent sensory pathways that bring information into the nervous system, as well as higher cortical projections that accommodate perception and generate appropriate physiological or affective responses. The content of consciousness resides primarily within the function of the bilateral cerebral hemispheres, and more specifically within associative cortices located in the medial and lateral aspects of the frontoparietal hemispheres. However, consciousness is not solely a cortical phenomenon. The level of consciousness, the degree of wakefulness or arousal, depends critically on arousal circuits located in the brainstem and diencephalic structures. This dual nature of consciousness, requiring both intact bilateral hemispheres for content and functioning brainstem diencephalic arousal systems for wakefulness, is the key to understanding how focal lesions in specific locations can produce coma. The modern understanding of consciousness and arousal has deep historical roots. This concept was initially recognized by Konstantin von Economo, an Austrian neurologist who lived from 1876 to 1931, when he carefully reported the devastating epidemic of encephalitis lethargica that occurred in the first decades of the 20th century. Von Economo's critical contribution was his meticulous documentation of the clinical pathological correlations in these patients. He observed that patients afflicted with encephalitis lethargica had lesions concentrated in the midbrain and its connections to the diencephalon, findings confirmed through systematic post-mortem examinations. What was particularly striking was the variability in clinical presentations. Some patients exhibited symptoms resembling narcolepsy, with excessive daytime sleepiness, while other patients demonstrated prolonged pathological wakefulness. This observation was revolutionary because it provided early evidence that specific anatomical structures in the midbrain and diencephalon play critical and distinct roles in regulating the sleep-wake cycle and maintaining normal arousal states. Von Economo's work laid the foundation for our current understanding of the anatomical substrates underlying consciousness. Over the years following von Economo's observations, functional neurodiagnostic tools progressively refined our understanding of consciousness. Hans Berger developed electroencephalography technology to evaluate psychophysiological correlations, providing a window into brain electrical activity. Frederick Bremer, who lived from 1892 to 1982, made crucial contributions by correlating brainstem lesions with brain waveforms in experimental animal models. He demonstrated that lesions at the level of the colliculi produced profound sleep-like states, while lesions at the spinal medullary junction preserved sleep-wake cycling, pointing to the critical role of the upper brainstem in maintaining wakefulness. The landmark work of Giuseppe Moruzzi and Horace Winchell Magun in the mid-20th century definitively identified the reticular formation's role in arousal. Through elegant stimulation and lesion experiments, they demonstrate that electrical stimulation of the reticular formation produced arousal, while lesions produced coma. They coined the term ascending reticular activating system, a term we still use today to describe this critical arousal network originating in the brainstem reticular formation and projecting rostrally to the thalamus and cortex. Now let's turn to the clinical manifestations of disordered consciousness, beginning with the precise definition of coma. With regards to the spectrum of different levels of arousal, coma represents a deep unresponsive state from which, regardless of the strength or type of stimuli applied, no meaningful reaction can be elicited. This is not mere deep sleep from which a person can be aroused, nor is it a state of fluctuating responsiveness. Coma is characterized by persistent, profound unresponsiveness. To truly understand coma and to communicate clearly with colleagues and families, careful differentiation between the various states of altered arousal is absolutely warranted. Each state along this spectrum, from normal wakefulness through lethargy, obtundation, stupor, coma, vegetative state, minimally conscious state, and ultimately brain death, has distinct clinical features and different implications for prognosis and management. What fundamentally distinguishes coma from sleep is the combination of complete lack of reactivity to external stimuli and the absence of the normal cycling between sleep stages that characterizes physiological sleep. Let me walk you through the critical distinctions between coma and related states of altered consciousness. Differentiating coma from brain death relies fundamentally on the vital functions of the brainstem. In brain death, there is complete absence of all brainstem reflexes, no pupillary responses, no corneal reflexes, no gag, no cough, no spontaneous respirations, coupled with absence of cortical function. Sleep, although instinctively recognizable as different from coma, shares some superficial features on EEG. However, sleep is a physiological state that can be easily interrupted by external stimuli, whereas coma cannot. Coma typically manifests on EEG with high amplitude slow wave activity in the delta frequency range, suggesting suppression of the direct and indirect activating pathways projecting from the thalami to the bilateral cerebral cortex. The vegetative state consists of an unresponsive wakefulness pattern where EEG findings characteristic of the sleep-awake cycle become evident. In the minimally conscious state, there is demonstrable awareness of self or surroundings, evidenced by limited, though clearly purposeful responsiveness, such as visual tracking of objects or following simple commands inconsistently. These distinctions are critical for accurate prognostication and for guiding discussions with families about goals of care. Prediction of recovery from a comatose state always represents one of the most challenging aspects of clinical care, and it's often the question that weighs most heavily on the minds of families and healthcare teams. The etiology of the coma and the specific circumstances surrounding the event are often the most useful pieces of information in estimating both the likelihood of recovery and the potential length of the recovery process. For example, in cardiac arrest, the total downtime, the duration from collapse to return of spontaneous circulation, is a critical prognostic factor. Similarly, the reversibility of the underlying cause of coma matters greatly. Coma due to hypoglycemia or opioid overdose, once reversed, may resolve completely and rapidly, whereas coma due to massive bilateral hemispheric strokes has a far more guarded prognosis. The spectrum of possible outcomes is extraordinarily wide, ranging from complete and expedite recovery at one end through varying degrees of partial recovery and persistent disability to full dependence, progression to persistent vegetative state, or death at the other extreme. Accurate prognostication requires integration of multiple data sources: the clinical examination, the trajectory of change over time, electrophysiological testing, imaging findings, and laboratory results. The neuroanatomy and physiology underlying consciousness can be conceptualized as involving three distinct but overlapping spheres: alertness, attention, and awareness. Understanding how each sphere maps onto specific neuroanatomical structures is fundamental to localizing lesions that produce coma. Alertness, which represents the most basic level, simply being awake rather than asleep, strongly correlates with the normal function of the brainstem and diencephalon. Lesions that disrupt these structures predictably impair alertness, leading to stupor or coma. This is why small, strategically located brainstem lesions can produce profound coma, while much larger cortical lesions may not affect alertness if they're unilateral or if they spare the arousal networks. Attention, which represents a more sophisticated level of consciousness, requires the added processes from associative cortices located bilaterally in the cerebral hemispheres. Finally, awareness, the most complex and least understood sphere, leads to internal perception of one's circumstances and surroundings. Normal consciousness requires the integration of all three spheres, and different pathologies can selectively affect specific spheres, producing distinct clinical syndromes. Now let's examine the neuroanatomical substrate of arousal in detail, with particular focus on the reticular activating system. It is now well understood that different neurotransmitters play critical roles in different anatomical structures for the maintenance of the arousal system. Brainstem tracts associated with wakefulness collectively form what we call the reticular activating system, the structure first identified by Moruzzi and Magoon. As you can see in this diagram, the reticular activating system is not a discrete nucleus, but rather a complex network of neurons extending through the central core of the brainstem. The rostral or upper portion of the reticular formation and its ascending pathways send connections that reach hypothalamic and thalamic structures. These diencephalic structures serve as critical relay and amplification stations. From the hypothalamus, basal forebrain, and thalamus, projections then ascend to higher cortical regions throughout both cerebral hemispheres to achieve the full state of consciousness and wakefulness. The caudal portion of the reticular formation and its descending pathways are involved in motor control and modulation of sensory signals. This architecture tells us clinically that consciousness depends on a distributed network extending from the upper brainstem through the diencephalon to widespread cortical areas rather than residing in any single localized center. Let's now dive into the specific neurotransmitter systems and pathways that constitute the ascending arousal system, beginning with the primary excitatory neurotransmitters. Glutamate-containing neurons located in the pontomesencephalic region send projections to the intralaminar nucleus of the thalamus, the hypothalamus, and the basal forebrain. All of these target regions play crucial roles in maintaining alertness. Glutamate neurons also arise from the supramammillary nucleus in the posterior hypothalamus, sending projections to these same target structures. This redundancy and convergence suggest the critical importance of these excitatory glutamatergic projections for arousal. The next major system involves acetylcholine neurons located immediately adjacent to the reticular formation in the upper brainstem. These cholinergic neurons project prominently to the intralaminar nucleus of the thalamus. The mechanism by which acetylcholine promotes arousal involves indirect facilitation of excitatory signals. Specifically, the thalamus, once activated by cholinergic input, sends widespread excitatory projections to the cerebral cortex. Thus, acetylcholine neurons in the brainstem don't directly activate the cortex. They activate the thalamus, which in turn activates the cortex, creating a two-step amplification system. These glutamatergic and cholinergic systems represent the primary excitatory neurotransmitter pathways in the arousal system. Beyond glutamate and acetylcholine, several monoaminergic neurotransmitter systems contribute importantly to arousal and attention. Dopamine neurons in the mesocortical pathway project from the ventral tegmental area in the midbrain directly towards the prefrontal cortex. This pathway is particularly important for attention, executive function, and motivation, higher order aspects of consciousness beyond simple alertness. Norepinephrine neurons, originating in the locus coeruleus in the dorsal pons, exert a general excitatory effect on the thalamus and widespread cortical regions. What's particularly fascinating about locus coeruleus neurons is that their firing rate dynamically changes according to the behavioral state of consciousness. They fire rapidly during wakefulness and attention, slow during quiet wakefulness, and become nearly silent during sleep. The serotonin system, originating from neurons in the raphe nuclei along the midline of the brainstem, has complex and somewhat variable effects. The rostral aspect of the raphe nucleus projects to the forebrain, mesencephalon, and basal ganglia, modulating mood, arousal, and motor function. The caudal portion projects to the cerebellum and spinal cord. Together, these monoaminergic systems modulate arousal, attention, and various aspects of consciousness, working in concert with the excitatory glutamatergic and cholinergic systems. Rounding out our discussion of the neurochemical basis of arousal, let's examine histamine and several other important neuromodulators. Histamine neurons projecting from the tuberomammillary nucleus in the posterior hypothalamus play an important role in promoting alertness and wakefulness. This is why first-generation antihistamines, which cross the blood-brain barrier, produce pronounced sedation. They're interfering with a key arousal-promoting system. Several other contributors have variable or indirect effects on alertness. Adenosine, which accumulates during prolonged wakefulness, promotes sleep by inhibiting arousal-promoting neurons. This is why caffeine, which blocks adenosine receptors, has alerting effects. Orexin neurons, originating in the lateral hypothalamus, play critical roles in stabilizing wakefulness and preventing inappropriate transitions into sleep. Loss of orexin neurons is the cause of narcolepsy. GABA, the brain's primary inhibitory neurotransmitter, can promote sleep by inhibiting arousal systems, which is why GABAergic medications like benzodiazepines and barbiturates produce sedation. The decreased firing rate of arousal-promoting neurons is clearly evident during the sleep state. Understanding these systems helps us predict the effects of medications and metabolic disturbances on consciousness. Now let's turn from neuroanatomy and neurochemistry to clinical localization. From a localizing standpoint, coma can be attributed to lesions in one of two general locations, either bilateral hemispheres or diencephalic structures when the injury is simultaneous and widespread, or the reticular activating system within the upper brainstem, where even relatively small focal lesions can produce profound coma due to disruption of the ascending arousal pathways. Regardless of the initial location of the triggering event, once a patient is in a coma, both cortical and subcortical functions become globally depressed, with cerebral metabolic rate decreasing to approximately half of normal. The key concept to understand is that consciousness comprises an orchestra of intact pathways forming an integrated network distributed across multiple brain regions. When assessing a patient in a comatose state, the clinician must systematically consider injury to either the reticular activating system in the brainstem or to the bilateral diencephalic or cerebral hemispheric structures. Importantly, unilateral hemispheric lesions, no matter how large, typically do not cause coma unless there is secondary compression of the brainstem or contralateral hemisphere. With advances in neuroimaging, structural lesions causing coma have become much more easily and rapidly diagnosed. The systematic approach to the comatose patient begins with prioritizing history-taking, information about the circumstances surrounding the event that led to coma can tremendously guide the differential diagnosis. Did the patient have sudden collapse suggesting a vascular event? Was there witnessed trauma? Were there premonitory symptoms like headache or fever? Was the decline gradual or abrupt? This context is invaluable. The physical examination of the comatose patient is specifically designed to aid in anatomical localization. Given that the reticular activating system extends through almost the entire rostral caudal extent of the brainstem, subtle findings on examination can provide hints towards lesions affecting different brainstem regions. The beauty of the brainstem examination is that different cranial nerve nuclei are located at different vertical levels, so specific patterns of cranial nerve dysfunction can localize lesions with remarkable precision. In the event that all surrogate markers of brainstem function are intact, then higher lesions affecting diencephalic or cortical structures become the primary suspects. It's critical to remember that cortical lesions to produce coma would require simultaneous bilateral insult to both cerebral hemispheres. The initial assessment of the comatose patient must always begin with vital signs, as these provide critical clues to underlying pathophysiology and identify immediately life-threatening derangements. Hypotension is concerning because cerebral autoregulation has limits. Mean arterial pressure of 60 millimeters of mercury is used as a reference threshold, below which cerebral perfusion may become inadequate, but individual considerations are absolutely essential. A previously hypertensive patient may require higher MAPI to maintain adequate cerebral perfusion. The key concern with hypotension is cerebral perfusion pressure, calculated as MAPI minus intracranial pressure. When MAPI falls too low or when intracranial pressure is elevated, cerebral perfusion pressure drops, potentially causing ischemic injury. On the opposite end of the spectrum, severe hypertension can directly provoke both ischemic and hemorrhagic strokes. However, hypertension can also be a physiological response to, rather than a cause of, coma. Specifically, hypertension can be a manifestation of increased intracranial pressure, recognized as part of the classic Cushing triad, which consists of hypertension, bradycardia, and abnormal respiratory patterns. Recognizing this distinction, hypertension as cause versus effect, is crucial for appropriate management. Continuing with the initial assessment, respiratory patterns provide valuable localizing information in comatose patients. Respiratory patterns are often irregular in patients with brainstem lesions, though importantly, they can also manifest in cases of intoxication with certain drugs. However, specific respiratory patterns can provide strong hints towards the anatomical level of injury within the brainstem or suggest bilateral hemispheric dysfunction. Body temperature is another vital parameter requiring careful assessment. Hyperthermia can be seen in multiple contexts, most commonly metabolic disturbances or infectious processes such as sepsis or central nervous system infections like meningitis or encephalitis. Neurogenic hyperthermia is typically associated with hemorrhage within the subarachnoid space or with direct hypothalamic lesions that disrupt the brain's thermoregulatory center located in the anterior hypothalamus. And it's important to recognize that neurogenic hyperthermia typically develops over time, hours to days after the initial injury, rather than being an immediate initial manifestation. Therefore, fever present immediately at presentation of coma is more likely to be infectious or metabolic, whereas fever developing days into the hospital course in a patient with subarachnoid hemorrhage may be neurogenic. To standardize assessment and communication about the level of consciousness, two widely used scoring systems deserve discussion. The Glasgow Coma Scale, universally known as the GCS, has been the standard tool for decades. It assesses three different domains: eye-opening, verbal responses, and motor responses, combining these to generate a total score. The maximum score is 15 points, indicating a patient who is spontaneously awake, fully oriented, and following commands normally. The minimum possible score is 3 points, seen in cases of complete unresponsiveness. Traditionally, a GCS score of 8 or less defines coma. The full outline of unresponsiveness score, abbreviated as 4 score, represents a more recent development that addresses some limitations of the GCS. The 4 score has similar components, including assessment of eye responses and motor responses, but it adds explicit evaluation of brainstem reflexes, including pupillary light reflex, corneal reflex, and cough reflex, which are not formally included in the GCS. Additionally, the 4 score includes detailed assessment of breathing patterns. The score ranges between 16 in fully awake and interactive patients and 0 in patients with complete absence of all responses. The advantage of the 4 score is that it can be used in intubated patients where verbal response cannot be assessed. Now let's examine in detail the specific respiratory patterns that can be observed in comatose patients and their localizing value. Cheney-Stokes respiration is characterized by a distinctive cyclic pattern with crescendo respiratory volume and rate followed by a decrescendo period, which may progress to a brief period of complete apnea before the cycle repeats. This pattern localizes to either bihemispheric lesions or to brainstem lesions. Apneustic breathing consists of a sudden prolonged inspiratory gasp with a pause at the end of inspiration, followed eventually by exhalation. This distinctive pattern localizes quite specifically to the tegmentum of the lower pons. Cluster breathing manifests as frequent, short, irregular, and shallow breathings occurring in clusters followed by an apneic period and can be seen with either bihemispheric or pontine lesions. Ataxic breathing, also called Biot's respiration, is characterized by completely erratic, irregular breathing that is unpredictable in both volume and frequency. This pattern may progress to agonal breathing and suggests severe brainstem injury, specifically to the tegmentum of the lower pons. Finally, central neurogenic hyperventilation consists of sustained, rapid, shallow breathing, typically around 40 breaths per minute, that is remarkably regular and persistent and can be seen with bihemispheric, midbrain, or pontine lesions. The ocular examination provides some of the most valuable localizing information in the comatose patient. Let's begin with pupillary assessment. Gaze position, pupillary size, reactivity to light, and symmetry between the two eyes are all critically valuable pieces of information that should be systematically documented. Pupillary size and reactivity can inform us about autonomic balance, the interplay between sympathetic and parasympathetic innervation to the iris muscles. Mid-sized pupils, typically around 4 to 6 millimeters, that are completely fixed, indicate loss of both sympathetic and parasympathetic autonomic tone. This finding suggests severe midbrain dysfunction. Pinpoint pupils, typically 1 to 2 millimeters in diameter, may suggest either disruption of the sympathetic ascending tracts, which would localize the lesion to the pontine region where these fibers descend, or they may indicate opioid intoxication, a critical distinction that can be life-saving. Dilated pupils, typically 7 millimeters or larger, suggest parasympathetic tone loss. When bilateral, this indicates midbrain dysfunction or anticholinergic intoxication. When unilateral, a dilated and fixed pupil ipsilateral to a mass lesion is a classic sign of uncal herniation, where the expanding mass compresses cranial nerve 3 fibers against the tentorial edge. This is a neurosurgical emergency requiring immediate intervention. Now let's examine resting gaze position, beginning with conjugate deviations. The term conjugate means that both eyes are deviated together in the same direction. Conjugate lateral deviation can be caused by lesions at 2 different levels, and distinguishing between them is critical for localization. Pontine lesions affecting the paramedian pontine reticular formation produce conjugate gaze deviation toward the side of the lesion. If the corticospinal tract is also involved, the patient will have hemipresis on the ipsilateral side, meaning the eyes and the weak limbs point toward the same side, toward the side of the lesion. Critically, in pontine lesions affecting gaze, the oculocephalic reflex is lost, meaning that when you perform the head turn maneuver, the deviation does not correct. In contrast, injury to the frontal eye fields in the cerebral cortex also produces conjugate gaze deviation, but the pattern is opposite. The frontal eye fields normally drive the eyes toward the contralateral side, so a lesion destroys this drive. However, because the brainstem gaze centers are intact with frontal lesions, the oculocephalic reflex is preserved, and the gaze deviation can be transiently overcome with the head turn maneuver. This deviation pattern relative to hemiparesis and response to oculocephalic maneuvers is absolutely critical for bedside localization. Beyond conjugate deviations, several other patterns of resting gaze position provide important localizing information. This conjugate lateral deviation means that the eyes are not aligned with each other. One eye is deviated laterally more than the other, or they're pointing in different directions. This can represent isolated cranial nerve 3 or VI palsies, or it may indicate internuclear ophthalmoplegia, depending on the specific details of the deficit. Lesions affecting cranial nerve T localize to the midbrain and adjacent structures as the oculomotor nucleus resides in the midbrain. Lesions affecting cranial nerve 6 localize to the pons where its nucleus is located. Internuclear ophthalmoplegia results from lesions affecting the medial longitudinal fasciculus, which connects the abducens nucleus on one side to the oculomotor nucleus on the opposite side, coordinating horizontal gaze. Downward deviation, where both eyes rest in a downward position, is suggestive of increased pressure over the tectum, the dorsal midbrain, compressing the vertical gaze centers. However, downward deviation is also commonly seen in metabolic encephalopathies. Finally, skew deviation represents a sustained asymmetric misalignment in the vertical plane, where one eye sits higher than the other. This finding is quite specific and suggests brainstem or cerebellar lesions affecting the vestibular pathways and vertical gaze control. Beyond assessing resting gaze position, we must carefully observe for spontaneous ocular movements in the comatose patient, as these provide additional localizing information. Roving eye movements are horizontal, slow, and conjugate, meaning both eyes move together smoothly from side to side in a random wandering pattern. The presence of roving eye movements is actually a favorable sign, as it indicates proper function of the oculomotor nuclei and the coordinating centers in the brainstem. Think about the complexity of the neural circuitry required to generate smooth, conjugate, coordinated horizontal movements. It requires intact function of both abducens nuclei, both oculomotor nuclei, and the medial longitudinal fasciculus connecting them. The presence of roving eye movements therefore suggests relatively intact brainstem function, implying that the cause of coma is more likely supratentorial or metabolic rather than a destructive brainstem lesion. In contrast, ocular bobbing represents a much more ominous finding. This consists of a vertical conjugate jerking movement characterized by a rapid downward phase where both eyes suddenly dart downward, followed by a slow return to the horizontal meridian. This distinctive finding is highly specific for a pontine lesion, often a large destructive lesion such as a pontine hemorrhage. Ocular dipping or inverse ocular bobbing has the opposite temporal pattern and indicates diffuse cerebral injury such as severe anoxic ischemic encephalopathy. The oculocephalic reflex, commonly known as the doll's eye reflex, and caloric testing provide critical information about brainstem function and help distinguish structural from metabolic causes of coma. The oculocephalic reflex should be attempted by performing a sudden head turn, rapidly rotating the head from side to side while observing the eyes. However, in cases where neck instability is suspected, caloric testing should be used instead, as it elicits the same pathways without requiring neck manipulation. A positive reflex consists of conjugate deviation of the eyes contralateral to the direction of head turn. When you turn the head to the right, the eyes deviate to the left. This response indicates intact brainstem function in the context of suppressed higher cortical signals. Disconjugate responses during this test suggest an underlying cranial nerve palsy localizing to the brainstem. Caloric testing elicits the same signal pathways using a different stimulus. Instillation of cold water to the external ear canal causes conjugate gaze deviation toward the opposite side. Instillation of warm water causes conjugate gaze deviation toward the same side as stimulation. The mnemonic COWS, cold opposite, warm same, is used to remember the fast phase of nystagmus that occurs in awake patients. In comatose patients with intact brainstem function, you see only the slow phase, tonic deviation, without the corrective fast phase. Absent responses to caloric testing indicate either brainstem dysfunction or certain drug intoxications like barbiturates. The motor system examination in the comatose patient provides essential information about the level and severity of neurologic injury. Observation is absolutely key to the initial assessment before any stimulation is applied. The first step is carefully noting any spontaneous movements at rest and thoughtfully deciding whether these movements are purposeful or not. Spontaneous purposeful movements, such as reaching up to scratch the face, adjusting position, or pulling at tubes or lines, indicate at least some preserved cortical function and consciousness, suggesting the patient may not be truly comatose. Following observation, we proceed to apply stimulation, typically starting with verbal stimuli, progressing to gentle tactile stimulation, and if necessary escalating to noxious stimulation such as firm pressure on the nail bed or supraorbital pressure. Motor movements elicited in response to stimulation should be characterized as either reflexive or localizing. Localizing responses involve any movement that is directed appropriately toward the side of stimulation in an apparent attempt to remove or escape the noxious stimulus. Localizing responses indicate preserved cortical function and corticospinal pathway integrity, and they carry a better prognosis than reflexive posturing. Reflexive movements, including decorticate and decerebrate posturing, indicate loss of cortical modulation and suggest more severe injury. Let's now discuss the specific posturing patterns and their prognostic significance in detail. Decorticate posturing, also called abnormal flexion, consists of flexion of the upper extremities at the elbow and wrist with adduction of the arms, combined with extension of the lower extremities. This pattern suggests damage to the corticospinal tracts above the level of the red nucleus in the midbrain, with the red nucleus still functioning and producing the characteristic flexion pattern. Decerebrate posturing, also called abnormal extension, consists of extension and internal rotation of all four extremities, often with wrist flexion. This pattern suggests damage at the level of the midbrain or upper pons below the red nucleus, with the vestibulospinal tracts now dominating motor output and producing extension. Decerebrate posturing generally indicates more severe injury and carries a worse prognosis than decorticate posturing. For flaccidity, complete absence of any motor response even to the most noxious stimulation, indicates the most severe injury and suggests either very deep coma or spinal cord injury. It's critical to recognize that these posturing patterns are not voluntary movements. They are stereotyped, reflexive responses that occur automatically in response to stimulation, reflecting the level at which normal cortical modulation has been lost. The distinction between localizing responses and posturing is not merely descriptive, it has real clinically meaningful prognostic significance. Now let's examine the specific clinical syndromes produced by lesions at different levels of the brainstem, beginning with the midbrain. Midbrain lesions produce a characteristic constellation of findings that reflect the structures housed at this level. The most classic finding is the fixed mid-sized pupil, typically 4 to 6 millimeters, that doesn't react to light. This reflects damage to both the sympathetic and parasympathetic pathways as they traverse the midbrain. Oculomotor nerve involvement, either through direct nuclear damage or fascicular involvement, produces ipsilateral cranial nerve 3 palsy with a dilated, fixed pupil, ptosis, and a down-and-out eye position. Vertical gaze palsies are characteristic of midbrain lesions affecting the rostral interstitial nucleus of the medial longitudinal fasciculus and the interstitial nucleus of Cajal, which control vertical eye movements. The classic parinoid syndrome or dorsal midbrain syndrome consists of upgaze palsy, convergence retraction, nystagmus on attempted upgaze, light near dissociation of the pupils, and lid retraction. This syndrome is produced by lesions affecting the dorsal midbrain, typically from pineal region tumors or hydrocephalus compressing the tectum. Motor findings with midbrain lesions can include contralateral hemiparesis from corticospinal tract involvement or the classic crossed syndromes, where ipsilateral cranial nerve findings are combined with contralateral motor deficits. Pontine lesions produce a distinct clinical syndrome that differs importantly from midbrain lesions. The pons is the largest segment of the brainstem and contains multiple critical structures. Pupillary findings with pontine lesions are characteristically pinpoint, typically 1 to 2 millimeters, due to disruption of the descending sympathetic fibers that traverse the lateral tegmentum of the pons. Despite their tiny size, these pinpoint pupils retain their reactivity to light, which is an important distinguishing feature from the fixed pupils of opioid intoxication, where pupils are also pinpoint but may be less reactive. Horizontal gaze is controlled by the paramedian pontine reticular formation in the pons. So pontine lesions can produce ipsilateral horizontal gaze palsy. Cranial nerve 6 palsy produces ipsilateral abduction weakness, and cranial nerve 7 involvement produces ipsilateral facial weakness. The combination of ipsilateral cranial nerve 6 and 7 palsies with contralateral hemiparesis is called Millard-Gubler syndrome, a classic crossed brainstem syndrome localizing to the ventral pons. Large bilateral pontine lesions, such as massive pontine hemorrhages, can produce the devastating locked-in syndrome, where the patient is conscious but completely paralyzed except for vertical eye movements and blinking, which are controlled by midbrain structures above the lesion. Completing our survey of brainstem syndromes, let's examine medullary and diencephalic lesions. The medulla contains the vital centers for cardiovascular and respiratory control, so lesions here can be immediately life-threatening. The classic medullary syndrome is Wallenberg syndrome or lateral medullary syndrome produced by infarction in the territory of the posterior inferior cerebellar artery or the vertebral artery. This syndrome produces a characteristic constellation including ipsilateral facial numbness, contralateral body numbness, ipsilateral Horner syndrome with ptosis and meiosis, ipsilateral limb ataxia, dysphagia, and hoarseness. Importantly, Wallenberg syndrome typically does not produce coma because it affects the lateral medulla, sparing the central reticular formation. However, bilateral medullary lesions or lesions affecting the central medullary reticular formation can produce coma or profound impairment of consciousness. Diencephalic lesions affecting the thalamus and hypothalamus can produce coma through several mechanisms. Bilateral thalamic lesions, whether from infarction in the territory of the paramedian thalamic arteries, hemorrhage, or metabolic injury, can produce profound coma despite their relatively small size because the thalamus serves as the critical relay station for the ascending arousal system. Hypothalamic lesions can produce alterations in consciousness through disruption of the arousal circuits in the posterior hypothalamus, as well as through metabolic derangements from disruption of hormonal regulation. Neuroimaging plays a central role in the evaluation of the comatose patient, and understanding the strengths and limitations of different modalities is essential for appropriate utilization. Computed tomography of the brain without contrast should be obtained urgently in virtually all comatose patients where the etiology is not immediately apparent. CT is fast, widely available, and excellent for identifying the conditions that most urgently require intervention: hemorrhage, large infarcts, hydrocephalus, and mass lesions with herniation. The presence of blood is immediately apparent on non-contrast CT as hyperdense material, allowing rapid identification of intracerebral hemorrhage, subarachnoid hemorrhage, subdural hematoma, and epidural hematoma. CT angiography should be added urgently when basilar artery occlusion is suspected, as this is a potentially reversible cause of devastating brainstem injury where time to treatment is critical. Magnetic resonance imaging provides exquisite anatomical detail and is superior to CT for evaluating the posterior fossa, brainstem, and small lesions. Diffusion-weighted imaging is particularly valuable for identifying acute ischemic strokes within minutes to hours of onset, long before they become visible on CT. MRI is also superior for identifying subtle brainstem lesions, white matter abnormalities, and metabolic encephalopathies. However, MRI takes longer to obtain, requires patient cooperation or sedation, and is not always immediately available, making CT the initial imaging modality of choice in the acute setting. Electroencephalography, or EEG, plays an increasingly important role in the evaluation and management of comatose patients. The primary indication for EEG in coma is to detect non-convulsive seizures and non-convulsive status epilepticus, which can be the cause of or a complication of coma and which cannot be detected by clinical examination alone. Studies have shown that non-convulsive seizures occur in a significant proportion of comatose patients, particularly those with acute brain injuries, and that these seizures may contribute to ongoing neuronal injury. Continuous EEG monitoring, rather than a single routine EEG, is preferred in comatose patients because seizures may be intermittent and easily missed on a brief recording. Beyond seizure detection, EEG provides valuable information about the overall level of brain function and can help with prognostication. Certain EEG patterns, such as burst suppression, generalized periodic discharges, and alpha coma, have specific prognostic implications. The presence of sleep architecture on EEG, even in comatose patients, is generally a favorable sign suggesting preserved thalamocortical connectivity. Quantitative EEG analysis, which uses computer algorithms to analyze large amounts of EEG data, is an emerging tool that can detect subtle changes in brain activity that might not be apparent on visual inspection of the raw EEG tracing. Beyond EEG, evoked potentials provide complementary information about the integrity of specific sensory pathways and have established roles in prognostication. Somatosensory evoked potentials, abbreviated SSAPs, assess the integrity of the somatosensory pathway from peripheral nerve through the spinal cord, brainstem, and thalamus to the primary somatosensory cortex. Bilateral absence of the N20 cortical response, the cortical potential generated approximately 20 milliseconds after median nerve stimulation, is one of the most reliable predictors of poor outcome in post-cardiac arrest patients, with a very low false positive rate for predicting poor outcome. Brainstem auditory evoked potentials assess the integrity of the auditory pathway through the brainstem and are particularly useful for evaluating brainstem function in patients where clinical examination is limited by sedation or neuromuscular blockade. Visual evoked potentials are less commonly used in coma evaluation, but can provide information about visual pathway integrity. Advanced multimodality monitoring, including intracranial pressure monitoring, cerebral microdialysis, brain tissue oxygen monitoring, and transcranial Doppler ultrasonography, provides real-time information about cerebral physiology and can guide management in selected patients with severe brain injuries. The integration of these multiple monitoring modalities, clinical examination, neuroimaging, EEG, evoked potentials, and physiological monitoring provides the most comprehensive assessment of brain function and the most accurate prognostic information. A functional MRI represents an exciting frontier in the assessment of comatose patients, offering the potential to detect covert consciousness, awareness that cannot be detected by standard behavioral examination. In landmark studies, some patients who appeared to be in a vegetative state based on clinical examination were found to have preserved cortical activation patterns on functional MRI when asked to imagine performing specific tasks such as playing tennis or navigating through their home. These findings have profound implications for our understanding of consciousness and for clinical practice, suggesting that some patients classified as vegetative may actually have some degree of preserved awareness. However, functional MRI is technically demanding, requires patient cooperation or at least absence of movement, and is not yet available as a routine clinical tool in most centers. Advanced structural MRI techniques, including diffusion tensor imaging, which maps white matter tract integrity, and voxel-based morphometry, which quantifies gray matter volumes, provide additional information about the structural basis of impaired consciousness. Arterial spin labeling perfusion MRI can quantify cerebral blood flow without contrast injection, providing information about regional perfusion abnormalities. Magnetic resonance spectroscopy can detect metabolic abnormalities in brain tissue, including elevated lactate suggesting ischemia and reduced N-acetylaspartate suggesting neuronal loss. These advanced techniques, while not yet standard of care, are increasingly being used in research settings and are gradually making their way into clinical practice. Now let's turn to the specific causes of coma due to primary brainstem and diencephalic lesions, beginning with vascular etiologies. Basilar artery occlusion represents one of the most critical vascular causes of brainstem coma and deserves special emphasis because it is potentially reversible with timely intervention. The basilar artery supplies the entire pons, midbrain, and portions of the thalamus, so occlusion can produce catastrophic brainstem injury. Clinical presentation is variable, but often includes sudden onset of coma, vertical gaze palsy, cranial nerve abnormalities, and motor deficits. The time window for intervention with intravenous thrombolysis or mechanical thrombectomy may be extended compared to anterior circulation strokes, and successful recanalization can result in dramatic neurologic recovery even after prolonged occlusion. CT angiography should be obtained urgently whenever basilar artery occlusion is suspected. Pontine hemorrhage, typically from hypertensive small vessel disease, produces sudden onset of coma with the characteristic pinpoint, pupils, quadriplegia, and loss of horizontal gaze. Large pontine hemorrhages carry a very poor prognosis with high mortality. Thalamic hemorrhage, particularly when bilateral or when involving the paramedian thalamic nuclei, can produce profound coma. Paramedian thalamic infarction from occlusion of the paramedian thalamic arteries that typically arise from a single common trunk can produce bilateral thalamic injury and coma despite the small territory involved. herniation syndromes represent a critical category of causes of brainstem and diencephalic dysfunction, occurring when supratentorial mass lesions produce sufficient pressure to displace brain tissue across the tentorium cerebelli or through the foramen magnum, compressing the brainstem from above. Understanding herniation syndromes is essential because they represent a neurosurgical emergency where rapid intervention can be life-saving. Central transtentorial herniation occurs when bilateral supratentorial pressure causes downward displacement of the diencephalon and brainstem through the tentorial notch. The clinical progression follows a rostral to caudal pattern, beginning with diencephalic signs, small reactive pupils, Cheyne-Stokes respiration, and decorticate posturing, and progressing through midbrain signs to pontine and finally medullary signs as the herniation advances. Uncal herniation occurs when a unilateral temporal lobe mass displaces the uncus of the temporal lobe medially and downward over the tentorial edge, compressing the ipsilateral cranial nerve 3 and the ipsilateral cerebral peduncle. The classic presentation is an ipsilateral, dilated, and fixed pupil, the first sign of uncal herniation, followed by ipsilateral oculomotor palsy and eventually contralateral hemiparesis. Subfalcine herniation, where the cingulate gyrus herniates under the falx cerebri, can compress the anterior cerebral artery and produce contralateral leg weakness. Upward transtentorial herniation and tonsillar herniation through the foramen magnum are additional patterns that can produce brainstem compression. Infectious and inflammatory causes of coma affecting the brainstem and diencephalon represent important diagnostic considerations, particularly because many are treatable if identified promptly. Bacterial meningitis can produce coma through multiple mechanisms: direct bacterial invasion and inflammation of the meninges and brain parenchyma, cerebral edema, hydrocephalus from obstruction of CSF flow, vascular complications, including septic thrombosis and vasculitis, and metabolic derangements from systemic sepsis. Empirical antibiotic therapy should be initiated immediately when bacterial meningitis is suspected, without waiting for CSF results if lumbar puncture will be delayed. Viral encephalitis, particularly herpes simplex encephalitis, can produce coma through direct viral invasion of brain parenchyma. Herpes simplex encephalitis has a predilection for the temporal lobes and limbic system, but can involve the brainstem in some cases. Empirical acyclovir therapy should be initiated immediately when herpes encephalitis is suspected. Autoimmune encephalitis, including anti-NMDA receptor encephalitis and other antibody-mediated encephalitides, can produce severe encephalopathy and coma. These conditions may mimic psychiatric illness early in their course and require a high index of suspicion for diagnosis. Wernicke encephalopathy, caused by thiamine deficiency, classically produces the triad of encephalopathy, oculomotor abnormalities, and gait ataxia, and can progress to coma if untreated. Empirical thiamine supplementation should be given to all comatose patients before glucose administration. The management of the comatose patient begins with the fundamental principles of emergency medicine: securing the airway, ensuring adequate breathing, and maintaining circulation, the ABCs. Airway management is the first priority. Comatose patients with a GCS of 8 or less typically require endotracheal intubation to protect the airway from aspiration and to ensure adequate ventilation. Rapid sequence intubation using appropriate sedation and neuromuscular blockade should be performed by experienced personnel. Once intubated, ventilator settings should target normal arterial CO2 levels of 35 to 45 millimeters of mercury, as both hypercapnia and hypocapnia can worsen cerebral injury. Hyperventilation to lower CO2 should be used only as a temporizing measure for acute herniation, not as a routine management strategy. Circulation should be maintained with adequate blood pressure to ensure cerebral perfusion. Hypotension should be treated aggressively with fluids and vasopressors as needed. Specific blood pressure targets depend on the underlying etiology. For example, in basilar artery occlusion, permissive hypertension may be appropriate to maintain collateral perfusion, while in intracerebral hemorrhage, blood pressure lowering may be indicated to prevent hematoma expansion. Glucose should be checked immediately and corrected if abnormal. Hypoglycemia is a rapidly reversible cause of coma that must not be missed, and hyperglycemia should be managed to avoid worsening ischemic injury. The following represents a summary of the current evidence-based approach to management of status epilepticus once ABCs and initial stabilizing measures are securely in place. Initial therapy consists of benzodiazepines, with lorazepam being the preferred agent due to its longer duration of action. Lorazepam should be administered as an intravenous or intramuscular push at a dose of 0.1 milligrams per kilogram, typically 4 milligrams initially in an average adult. This can be repeated as needed if the seizures persist, provided the airway has been secured. If seizures continue despite adequate benzodiazepine therapy, we immediately proceed to secondary therapy. Secondary therapy options include a loading dose of fosphenytoin at 20 milligrams per kilogram, phenytoin equivalents up to a maximum of 1 gram. Alternative second-line agents include valproic acid at 40 milligrams per kilogram up to a maximum of 3 grams, or levetiracetam at 60 milligrams per kilogram up to a maximum of 4.5 grams. Beyond second-line therapy, if seizures persist, we enter the realm of super-refractory status epilepticus. The American Epilepsy Society guidelines recommend either repeating second-line therapy with an alternative agent or proceeding to add continuous infusion anesthetic agents, including midazolam, thiopental, pentobarbital, propofol, or ketamine. These agents require continuous EEG monitoring to titrate to the desired level of seizure suppression. Patients evaluated after cardiac arrest represent a distinct clinical entity that deserves special consideration, as the management encompasses specific strategies aimed at preventing and treating brain injury resulting from hypoxic ischemic circumstances. The key physiological parameters to focus on include cerebral perfusion pressure, calculated as the mean arterial pressure minus the intracranial pressure itself when elevated, and optimization of oxygen supply through careful management of ventilation parameters and hemoglobin levels. Primary prevention of brain injury in the context of cardiac arrest lies almost purely in the quality of cardiopulmonary resuscitation provided. High-quality CPR with minimal interruptions in chest compressions, adequate compression depth and rate, and early defibrillation when indicated are the interventions that have the greatest impact on neurologic outcomes. Once spontaneous circulation has been achieved, the fundamental goals of post-arrest care are threefold. First, to prevent recurrence of cardiac arrest by identifying and treating the precipitating cause. Second, to decrease the brain metabolic rate, reducing the oxygen and glucose demands of the injured brain. And third, to guarantee proper cerebral irrigation through maintenance of adequate blood pressure and oxygenation. Targeted temperature management has been used extensively in the post-cardiac arrest literature, with the fundamental goal of lowering the brain metabolic rate through controlled hypothermia and critically preventing fever, which is known to be associated with worse neurologic outcomes. In the main cases where prognosis is guarded or the range of possible outcomes is too broad to provide definitive predictions, fluent, compassionate, and ongoing communication with family members and designated decision makers takes absolute priority. Our role as physicians caring for comatose patients extends beyond the technical aspects of diagnosis and management. We must serve as guides and interpreters, helping families understand the disease process, the nature of the injuries, and the potential trajectories of recovery or decline. This understanding, developed through repeated conversations as the clinical picture evolves, provides families with the foundation they need to make informed decisions about future courses of action that are truly in the best interest of the patient. These are among the most difficult conversations we have in medicine. Families are facing the possibility of losing their loved one or of that person surviving with profound permanent disabilities. Our responsibility is to provide honest, balanced information, neither overly pessimistic nor falsely optimistic, acknowledging the genuine uncertainty that often exists in prognostication, especially early in the course. We must integrate all available clinical information, the examination findings and their evolution over time, the imaging studies showing the extent and location of injury, the electrophysiological data from EEG and evoked potentials, and the overall time course and trajectory. The process of shared decision-making, where the medical team provides information and recommendations, but ultimately the family's values and the patient's previously expressed wishes guide major decisions, is the ethical framework we should follow. Looking toward the future, research efforts are currently intensely focused on finding reliable tools and biomarkers that can guide clinical care and improve prognostic accuracy in comatose patients. This would, in turn, aid in identifying specific therapeutic targets and interventions that could improve outcomes in this vulnerable population. Many of these research efforts are dedicated specifically to post-cardiac arrest and severe traumatic brain injury populations, which represent relatively homogeneous populations in which standardized protocols can be implemented and outcomes systematically studied. However, the reality is that there's a remarkably broad range of pathologies that can cause or contribute to the comatose state, and the heterogeneity of these conditions makes it difficult to standardize management protocols or predict outcomes with confidence across all etiologies. Emerging tools that show particular promise include functional MRI for detecting covert consciousness, somatosensory evoked potentials, and quantitative EEG monitoring as surrogates of neurologic examination, and serum biomarkers such as neurofilament, light chain, and glial fibrillary acidic protein that reflect the degree of neuronal and glial injury. Multimodality monitoring, combining multiple physiological parameters in real time, may provide more meaningful prognostic information than any single modality alone. The end goal of all this research is to better support patients and families through these devastating illnesses while lowering mortality and reducing long-term dependence and disability. As we conclude this comprehensive review, let me synthesize the key take-home messages that should guide your approach to comatose patients. First and fundamentally, consciousness depends not on any single brain region, but on a distributed network involving the brainstem reticular activating system, the diencephalic structures, including the thalamus and hypothalamus, and the bilateral cerebral cortices. This distributed nature explains why small, strategically located lesions in the brainstem or bilateral diencephalon can produce profound coma despite their relatively small size. Second, the systematic neurologic examination, including assessment of pupils, eye position and movements, motor responses, and respiratory patterns, can localize the lesion to a specific level within the brainstem or identify a supratentorial cause. This bedside examination remains the cornerstone of evaluation and cannot be replaced by imaging or other tests. Third, rapid assessment and immediate treatment of reversible causes of coma can prevent permanent neurologic injury and even be life-saving. Time is absolutely critical. Fourth, definitive diagnosis and accurate prognostication require integration of the clinical examination with structural neuroimaging, functional studies including EEG and evoked potentials, and careful observation of the trajectory and evolution over time. Finally, in cases where outcomes are uncertain, compassionate and ongoing communication with families is an essential component of comprehensive patient-centered care. Let me leave you with practical clinical pearls that will immediately enhance your bedside evaluation of comatose patients. First, and most urgent, always rule out basilar artery occlusion emergently in any patient presenting with undifferentiated coma, where the etiology is not immediately apparent, or the CT angiography of the head and neck emergently. Second, commit the SNOOP's mnemonic to memory as your mental checklist for red flag features: systemic signs, neurologic deficits, acute onset in an elderly patient, and pattern changes or postural symptoms, or papilledema or precipitants like exertion. Third, use the Cow's mnemonic to correctly interpret caloric testing. Cold water produces conjugate gaze deviation to the opposite side. Warm water produces deviation to the same side. Fourth, carefully distinguish localizing motor responses, which indicate preserved cortical function and carry better prognosis, from reflexive posturing, decorticate or decerebrate, which indicates severe injury and worse prognosis. Fifth, learn to recognize specific respiratory patterns at the bedside, as they provide immediate clues to the anatomical level of lesion localization even before imaging is obtained. Finally, in post-cardiac arrest patients, resist the pressure to prognosticate definitively too early in the course. Current guidelines recommend waiting at least 72 hours after return of normothermia, and longer if targeted temperature management was used before making definitive prognostic statements. Thank you for your attention and engagement throughout this comprehensive exploration of coma due to primary brainstem and diencephalic lesions. We've covered extensive ground today, from the historical foundations of our understanding of consciousness and the pioneering work of von Economo, Moruzzi, and Magun, through the detailed neuroanatomy and neurochemistry of the ascending reticular activating system, to the systematic bedside examination techniques that allow precise anatomical localization, and finally to evidence-based management strategies for various causes of coma. The care of comatose patients represents one of the most challenging areas in clinical neurology and critical care medicine. These patients cannot tell us their symptoms, cannot cooperate with examination, and often have uncertain prognoses that place enormous emotional burdens on their families and on us as clinicians. Yet with systematic application of the principles we've discussed, understanding the functional neuroanatomy, performing meticulous neurologic examinations, rapidly identifying and treating reversible causes, integrating multiple diagnostic modalities, and engaging in honest, compassionate communication with families, we can optimize outcomes and provide excellent patient-centered care even in these most difficult circumstances. Every comatose patient deserves our very best efforts, our most thoughtful clinical reasoning, and our commitment to both aggressive treatment when appropriate and compassionate support always. I hope this presentation has equipped you with the knowledge and framework to approach these patients with greater confidence and competence. Thank you again for your time and commitment to improving the care we provide to our most vulnerable neurologic patients.